Anemia, reticulocyte index less than 3%. Sideroblastic anemia, iron deficiency anemia, thalassemia, anemia of chronic diseases, megaloblastic anemia, anemia of chronic renal failure, aplastic anemia, acute hemolysis, decreased MCH, decreased MCV, microcytic anemia, challenge oral iron. After 1 week, reticulocytes increase, then it is iron deficiency anemia. Continue oral iron for 6 to 9 months. If reticulocytes doesn't increase, do iron profile. If serum iron, ferritin transferrin saturation is decreased and TIBC is increased, it is iron deficiency anemia. If everything is decreased and serum ferritin is increased, it is anemia of chronic disease. If everything is increased except TIBC, then it is sideroblastic anemia. If iron, ferritin, transferrin saturation and TIBC is normal, it is thalassemia. If MCH is normal, MCV is normal, then it can be anemia of chronic renal failure or acute hemolysis. If it is associated with pancytopenia, it is aplastic anemia. If MCV is increased, it is macrocytic anemia. If it is associated with hypersegmented neutrophils, it is megaloblastic anemia. If reticulocyte index is greater than 3%, it is hemolytic anemia. Clinical features: jaundice, splenomegaly, hemoglobinuria. If it is in child, it is inherited. If the onset is since birth, then it can be hereditary spherocytosis associated with splenomegaly. If the onset is greater than 6 months, then it is thalassemia associated with splenomegaly. If the splenomegaly is absent, it can be G6PD or sickle cell anemia. In adults, it is acquired. If it is associated with clumping and spherocytes, then it is autoimmune hemolytic anemia. If it is associated with pancytopenia, then it is paroxysmal nocturnal hemoglobinuria.